Welcome to the deep dive. Today, we're tackling something that sounds maybe a bit dry on the surface. OPCS 4.60.
Right.
Okay, let's unpack this a bit. This might sound like pure administration, but honestly, this is the current mandated UK standard. It dictates how surgical procedures, interventions, everything really, gets recorded across the NHS.
It's the engine room.
Exactly, the
Yeah.
financial engine room.
Yeah, precisely. Our mission today is to explain this classification standard DAPB 00084 is the official tag talk about its structure, and crucially, it's linked to hospital funding.
Okay.
And just to note, this specific version, 4.0, it's been mandatory since April 1st, 2023, and that runs until March 31st, 2026.
Got it. So before we wade into the money side, which sounds fascinating, let's make sure we're all clear, especially for you listening. What does OPCS-4 actually classify, and maybe just as importantly, what doesn't it?
Good question. OPCS-4 classifies what was done, the procedure, the intervention itself.
Like the action taken.
Exactly. Think of it like OPCS-4 is the code for changing the car tire. It's totally separate from ICD-10.
Right, ICD-10 being the diagnosis.
Yes. ICD-10 is the reason for the actions of the flat tire in our analogy.
Wow.
The disease, the condition, they have to work together, you see, concurrently. That's how you get the full picture of what happened clinically and, well, why it caused what it caused.
Okay, so that's the what. Let's get into the why, the strategic significance. Why is getting this coding right so incredibly critical? Are we really saying NHS funding turns on getting a 4-character code right?
We absolutely are. It sounds fragile, maybe, but yes.
Doesn't that seem risky, like open to errors or even, gaming the system?
Well, the stakes are high, definitely. Here's the core function. These OPCS 4.10 codes, they are the essential input, the raw data, used to generate healthcare resource groups. HRGs.
HRGs, okay.
And HRGs are basically the currency, if you like. They represent fixed price bundles for treatments within the NHS payment by result system, PBR.
Ah, PBR. Heard of that.
So you can see inaccurate coding, or maybe missing a code altogether. That leads directly to the wrong HRG being generated.
Which means the hospital gets the wrong payment.
Exactly. The wrong tariff. Potentially huge financial losses just from a coding slip-up.
Wow. Okay, that really highlights the importance. So let's talk structure then. You mentioned this rigid 4-character alphanumeric thing, like A01.1. Why so rigid?
Precision is payment, essentially. The structure itself provides that. The first letter points to the body system, cardiology, neurology, whatever. Then the numbers drill down into the specifics of the actual procedure. But, and this is quite clever, to get maximum detail without making the main code ridiculously long.
Yeah.
They introduce subsidiary classifications.
Okay, is that where the Y's and Z's come in that I read about?
That's it, exactly. Chapters Y and Z. They're used separately alongside the main code to add extra layers of detail. So chapter Y tells you the method or technique. Was it open surgery, robotic, laparoscopic?
Right.
And chapter Z specifies the site, the precise anatomical location, or maybe laterally, left side, right side.
Ah, okay.
This kind of multi-axis approach stops a really complex, specific intervention getting bundled and underpaid as something more generic.
Makes sense. And medicine moves fast, so the classification has to keep up, right? This 4.0 update sounds like it was pretty significant. 34 new subchapters, 236 new codes.
It was a big one, yeah. Those updates are vital for capturing clinical innovation. They're sort of the financial safety net for progress.
Can you give an example? Like, what sort of high-tech thing gets a specific code now?
Sure. Take gastroenterology. There's a new code, G20.2, that's specifically for fiber optic endoscopic coagulation of a bleeding esophagus lesion using hemostatic spray. Very specific.
Okay.
Or in cardiology, K62.6. That captures percutaneous transluminal intermittent occlusion of the coronary sinus. These aren't everyday procedures. They're complex, often costly.
And giving them their own code means?
Means they get properly reimbursed. They aren't just lumped under an older, perhaps simpler, less costly code by default. It ensures fairness in funding for advanced care.
Right. But operationally, that sounds like a headache for hospitals. You mentioned they have to manage dual coding.
They do, yes. It's a mandatory dual coding environment for a period. They must use the new 4.10L standard for any patient discharged on or after April 1st, 2023.
Okay.
But for discharges before that date, they still need to use the older 4.9 system for reporting or auditing.
It's quite the administrative juggling act.
Oh, it is a burden, no doubt.
Yeah.
But you have to remember, this whole system isn't just, good practice. It's foundational to NHS finance. It's driven by law, the Health and Social Care Act 2012.
So not optional.
Not optional at all. It's mandated revenue assurance.
Yeah.
And the system itself keeps evolving. It used to be just about surgical operations, but now it's much broader at classification of interventions and procedures. Reflects modern medicine better.
That adaptability. That actually leads us perfectly to our final thought, something for you to mull over. The next version, OPCS-4.10 is planned for April 2026. And the plans explicitly mention capturing emerging tech, things like AI-enabled diagnostics, image-guided interventions. So the provocative question is, how on earth will the NHS classify and pay for technology that might not involve a scalpel at all? What's the HRG for an algorithm?
That is certainly something to think about. How do you code and price something fundamentally different?
Exactly, something for you to ponder.